I am Teresa McDeasy. I'm a physician assistant. I've been working in pulmonary critical care since 2013, and currently I'm over at Jenny Edmondson in Council Bluffs. And like she said, today we're going to talk about chest tubes. Disclosures, I don't have any conflicts or interest or any disclosures. Objectives, she already kind of touched on some of those. I know a lot of us have been in medicine for some time and have had at some point in our career come across a patient with a chest tube. Today is kind of the basics of chest tubes. For some of you, it may be old hat and just a nice review, but for others, perhaps you haven't had a patient with a chest tube in a while. So hopefully this will be some good reminders on how to set up, how to interpret the findings on the drainage system itself. So the first thing is the purpose of the chest tube. Going really basic, it's you put a chest tube in to remove either liquid or air from the pleural space, and we do this for the purpose of trying to get the lung to expand all the way. You can see in that picture there on the slide, a common chest site tube insertion site would be like intercostal spaces 2 or 3 for a pneumothorax or when there's air in that intrapleural space. Effusions tend to be a little bit lower, sometimes more like the 4th or the 6th intercostal space. You can even go a little bit lower depending on if you have an ultrasound guidance to help you see where that pocket of fluid is. Indications for a chest tube, there's these reasons here listed: pneumothorax, so air that's trapped in that intrapleural space; hydrothorax, some type of fluid; hemothorax, blood; chylothorax, lymph; and empyema would be infection or a pus-like substance. So those are all some reasons to put a chest tube in and to drain out either air or fluid from that space. We also see patients that have chest tubes after surgery. So any of your post-thoracotomy patients will sometimes come up to the floor with the chest tube in place. You can also use chest tubes for instilling sclerosis agents like talc or doxycycline. Those can be put into that intrapleural space for the purpose of achieving pleurodesis, or when you're bringing the visceral pleura and the parietal pleura together, kind of scarring them together so that you're basically trying to obliterate that space so air and fluid can't accumulate in that area. These are some good diagrams. So that top left diagram there, you can see that's a pneumothorax. You've got air coming in from the outside into the space. It's filling the intrapleural space and causing an increased pressure on the lung, causing it to collapse down. Here is a picture right to the left of that is a picture of an X-ray image that has a pneumothorax. So you can see this is a left-sided pneumothorax, so where you're kind of seeing pretty clear through on the chest wall there. This is all. And over here we have pleural effusion, so you can see pleural fluid is collecting around this lung area, and that's where you're going to put the chest tube in there to drain it out. Here's a picture of a chest X-ray example of a pleural effusion. See how you can no longer see the cardiac outline or shadow. Instead, you get this nice line up here that's a fluid line. The drainage system itself. So for the purpose of this presentation, I'm using the Oasis atrium drainage system. I'm using that because that's what is used at Jenny Edmondson and at Methodist Main Hospital. So for explaining for some people that might be tuning in from outside of our health system, there are other drainage systems like Pleurovac, but for the purpose of this presentation, we're going to be referring to the Oasis. The first thing to know about the Oasis is being able to label all the different parts on it. I get phone calls where people will try to tell me, well, the suction is at -10, so where is that on here? So knowing what little areas you're actually referring to helps for better communication between yourself and the provider. Or I get calls saying like, there's fluid leaking. Well, where's the fluid leaking from? And they can't tell me the difference between, the 2 different reservoirs. So The first one here is letter A, and that's the suction regulator. So that is where you turn the dial based on whatever the provider has ordered for suction. Typically, the standard is -20. Sometimes providers like a little less, sometimes they go a little bit more, but that's the dial you turn for when a provider is asking for negative suction to be applied. On the wall, that always stays at -80, and we'll get into that a little bit more. B is the water seal chamber. This is where that blue fluid is. And you can, what happens is as air is pulled out of the intrapleural space, it goes through the fluid chamber collection and then siphons through to the water seal chamber and bubbles out and gets removed by negative pressure. C, down at the bottom of that water seal chamber, that's where you'll see bubbling happening if there is an air leak present. D is the water or the fluid collection chamber. This is where the fluid that's actually in the pleural space from the patient is draining out. So this will be their pleural fluid drainage. And then E is the suction monitor bellows. And that's that kind of little orange accordion looking structure there. And it will pop out all the way to that delta sign or that triangle when suction is being applied. Sometimes it may not pop all the way out to the delta if there are pressures less than -20 being applied. But if you've got suction of 20, that bellow should be out. If it's not, then you've got some issues with a connection in your chest tube system. Oh, and back on this page, there is a float ball, kind of hard to see in this picture. It's that white little ball. It tidals up and down, kind of bounces up and down with respiration. Drainage system setup. So this is a nice little cheat sheet. It's actually a reference card in the back of the Oasis drainage system when you're going to set it up. So you've kind of got a cheat sheet with you when you go to set up a patient with a chest tube. So it's a nice little reference to refer to if needed. But our video is going to get into this a little bit more, but for the most part on this slide, things I'm going to point out is when you're setting up the drainage system, you're going to add the 45 mLs of sterile water to this little H suction port here, and it will drain into the water seal chamber. That's where that blue fluid is. You want to make sure that it's, built up or filled up to at least the 2 centimeter line. Then you're going to connect the patient's thoracic tube to the manufacturing tubing. So P is going to get connected to the patient's chest tube. And then you're going to apply suction to the system and then turn on the suction source. So on the wall, it will always be set to -80. And on the suction regulator that we pointed out, letter A, that will be whatever the provider ordered for suction. So -20 is pretty standard, but there may be some variation depending on what provider you have. When you are setting up a drainage system, you're going to need all the like chest tube canister and all the wall suction supplies to get set up. I have had, we've got a patient example where a patient came in, got a chest tube placed overnight. I came in around 9 in the morning to see the patient for a consult. The patient has a thoracic tube coming out and it's directly hooked to wall suction. There was no drainage system set up on the floor. So they were set to intermittent -40 suction. That is incorrect. That is a bad idea to do that because there's no way to know exactly how much pressure is being applied to the patient's intrapleural space. So always make sure that you set up your drainage system correctly. I have a video here. I really hope it works because this video is awesome and a really, really good reference. I am a visual learner, and so this video is great for getting set up.
First, remove the CSR wrapped unit from the sterile outer bag. Carefully open the CSR wrap using sterile technique and only enter the chest drain into the sterile field. Each unit comes equipped with a large, easy-to-grip handle that makes handoff and patient transport safe and easy. The sturdy swing-out floor stand should be open for setup convenience and for placement onto the floor. To begin, fill the water seal to the 2 centimeter line with the 45 milliliters of pre-packaged sterile water provided with each drain. Simply remove the pre-packaged sterile water ampule from the back of the drain, twist off the top of the ampule, and insert the tip of the water ampule into the suction port. Empty its entire contents by squeezing the ampule until all of the water empties into the drain and fills the water seal to the indicated fill line. Discard the ampule. Next, connect the chest drain to the patient by inserting the patient tube connector directly into the thoracic catheter. The patient is now on gravity drainage or to water seal. To apply suction when prescribed by a physician, connect the suction source vacuum line directly to the chest drain suction port located on the top of the drain. Turn the suction source on and increase the vacuum to -80 millimeters of mercury or higher. A suction monitor bellows provided on the Oasis offers visual indication of sufficient operating vacuum levels for best performance. The suction monitor bellows must be expanded to the delta mark where indicated or beyond for a standard -20 centimeters of water or higher regulator setting. Visual expansion of the bellows across the suction window will confirm adequate suction operation. The Oasis suction regulator is preset to a -20 centimeters of water suction pressure level directly out of the package. Suction pressure can be adjusted to any desired pressure level between -10 centimeters of water and up to a maximum suction pressure of -40 centimeters of water. Changing the regulator suction control setting is easily done by adjusting the rotary suction control dial located on the side of the drain. Simply dial down to lower the suction pressure setting and dial up to increase the suction pressure setting. When changing from a higher to a lower level, use the manual high negativity vent located on top of the chest drain after regulator adjustment to reduce excess vacuum down to the lower prescribed level. As with any chest drainage system, the drain must be placed below and kept below the level of the patient's chest in an upright position to maximize drainage efficiency. We recommend hanging the unit bedside using the multi-position hangers provided. The integrated flexi hangers accommodate today's newer bed designs and allow single hand placement and transport. All patient tubes and suction connections should be routinely checked to ensure proper leak-proof operation and chest tube patency. Like all Oasis models, the 3600 single collection chest drain incorporates a large writing surface with big, bold numbers and easy-to-read fluid level graduations. The first collection chamber column is graduated in small 1 milliliter increments, up to 100 milliliters in brightly colored bold numbers. Then, in 2 milliliter increments up to 200 milliliters. Subsequent collection chamber columns are graduated in 10 milliliter increments up to the maximum drain capacity of 2100 milliliters. For the protection of you and your patients, Getinge's entire family of Oasis chest drains do not contain natural rubber latex. Depending upon your hospital's preferred sampling technique, samples of drainage fluid can be taken directly from the patient tube by forming a temporary dependent loop and inserting a 20 gauge or smaller needle with syringe at a shallow angle. Samples can also be taken directly from the Lurelock sampling port located on the patient tube connector. A water seal is a simple one-way valve which allows air to exit the chest and prevents air from returning to the patient under normal conditions. It is also a very useful diagnostic tool as it can show even the smallest trends of an air leak as well as changes in intrathoracic pressure. Assessing patient air leaks is easy with Getinge's blue tint water and graduated air leak monitor. Continuous bubbling observed in the water seal confirms a persistent air leak in either the patient's thoracic cavity or possible tube connections. Intermittent bubbling with gentle float ball oscillation confirms the presence of an intermittent air leak. And no bubbling with minimal float ball oscillation at the bottom of the water seal indicates that no air leak is present. Bubbling from right to left in the air leak monitor must be present to confirm an active air leak. The Oasis graduated air leak monitor allows visual detection of air leaks from a low volume of 1 to a larger air leak volume of 5. Air bubbles passing through the graduated air leak monitor help the clinician assess air leak patterns and patient air leak trends. Changes in intrathoracic pressure can be determined by observing the level of the blue tint water and float ball in the graduated water seal column. Getinge's blue tint water and float valve makes changes in patient pressure easy to monitor. When the system is connected to suction, patient intrathoracic pressure equals the suction control setting plus the float valve water column level. For gravity drainage applications, patient pressure equals the float valve water column level only. Each Oasis chest drain incorporates a high negativity float valve, which is located at the top of the water seal chamber. During normal or deep inspiration, the float valve allows thoracic patients to draw as much intrathoracic pressure as they may require during each respiratory cycle. However, during prolonged periods of accumulating vacuum pressure, the float valve automatically lowers high vacuum pressure down to a lower level. The unique controlled release valve design protects your patients against prolonged exposure to excessive negative pressures, which can accumulate as a result of repeated patient tube milking or stripping. To manually lower the height of the water seal column when connected to suction, temporarily depress the manual vent located on the top of the drain until the blue water column lowers to the desired level. It is not recommended to depress the manual vent when suction is not connected or not operating. When monitoring a patient's chest drainage system, it's important to periodically check the water seal's operation and fluid level. If the water seal is either underfilled or overfilled, it should be adjusted accordingly to the prescribed maximum 2 cm level. Using a 20 gauge or smaller needle with syringe, adjust the water level via the grommet located on the back of the water seal chamber. In the event of an accidental knockover, upright the drain immediately and check all fluid levels. If required, the water seal level may be adjusted back to its original 2 cm level using a 20 gauge or smaller needle and syringe, as previously demonstrated. If blood has contaminated the water seal, it may be advisable to replace the chest drain with a new unit. If a knockover does occur, fluid drainage could potentially spill from one collection chamber to another. If this occurs, gently tip the drain to the right to return fluid back to the correct column, and then upright the drain. The Oasis features a water seal design with enhanced knockover protection, even when connected to suction. In the event of an accidental knockover, its patented knockover nozzles help minimize interchamber spillover for user convenience and patient safety. Most healthcare facilities routinely use suction for their patients, as it helps improve the rate and flow of fluid drainage from the patient. Suction also helps increase the rate and volume of airflow out of the patient to help maximize lung expansion and stabilize breathing dynamics. Getinge's suction control regulator continually adjusts for changes in patient air leaks and fluctuations in hospital wall suction, providing patient safety and system reliability. The highly visible suction bellows readily confirms adequate suction operation. If the bellows is observed to be expanded but less than the delta mark, the suction source vacuum pressure must be increased to minus 80 millimeters of mercury or higher. For a regulator setting less than minus 20 centimeters of water, any observed bellows expansion across the window will confirm suction operation. The bellows need not be expanded to the delta mark for suction pressures less than minus 20 centimeters of water, just visibly expanded in the window to confirm suction operation. For patient transport and gravity drainage applications, simply disconnect the suction source vacuum line from the blue suction line connector. As a safeguard against tension pneumothorax, an automatic positive pressure release valve opens to release accumulating positive pressure when such clinical conditions may arise. Its tamper-resistant design is located on the top of the drain. All Oasis models come equipped with a locking inline connector and removable patient tube clamp that provides convenient, simple disconnection after use, or rapid inline ATS blood bag attachment when required. The patient tube slide clamp must remain open at all times during system operation. It is recommended to position the patient tube clamp next to the inline connector for setup convenience and routine visual check. The patient tube clamp can be removed if desired. Disposal of chest drain and its contents should be in accordance with all applicable regulations.
All right. Well, hopefully that video was helpful for some of you that have not used a chest tube in a while. Okay, moving on. So they wanted me to include kind of what the power chart order set looks like for when a chest tube gets ordered. So you can see that after a chest tube is placed, they're going to get a chest x-ray to ensure correct placement. And so say if it was placed for a pneumothorax, maybe we'll already see the lungs starting to come back up at that time of an x-ray. Then you're going to get daily chest x-rays for the most part, just to ensure that the chest tube is still functioning and doing what it's supposed to, that there hasn't been, you know, a reaccumulation of pleural fluid in the space overnight. Maybe the chest tube's clogged, that kind of thing. Or sometimes you can see they have a chest tube in and they redeveloped like a large pneumothorax. So daily chest tubes or daily chest x-rays on a chest tube patient are very helpful. When setting up for chest tube placement, you're going to need consent. Like always with any procedure, you have to explain the risks and the benefits to the patient prior to the procedure. This order set also includes this amount of suction. Like I said, -20 is pretty standard. All the supplies that are needed to get set up for the chest tube placement, and then oxygen protocol. You'll see a lot of providers that still do 2 liters O2, regardless of what their oxygen saturation is for nitrogen washout, because that can help reduce some of the pneumothorax and help it get to resolution faster. Securing a chest tube. So some of these chest tubes are pretty small. I mean, I know there are some large bore chest tubes, but they're pretty small in most instances, especially if it was for a pneumothorax. They can get kinked really easily, and then they become a non-functioning tube and they're no longer doing their job. So you want to make sure when you are dressing a patient's chest tube that you have a non-occlusive dressing, and then you have your gauze pad that goes around it, and then you're going to secure it down with some tape or Tegaderm. But when you are doing that, you want to make sure that you are not at all kinking the tube and that all of the direction of the tube seems to be lining up to make the most sense. So I have walked into rooms where a patient had a chest tube on the right side anteriorly, and the chest tube came out and then took a sharp 180-degree turn across the patient's chest, and then they had the chest tube there on the left side on the floor. Well, obviously that chest tube was kinked because they made a 100-degree or 180-degree turn across the chest. So you want to make sure that you're setting up everything optimally so that chest tube stays pained. Also, you want to work to keep the chest tube coiled up on the bed, and you don't want it dangling off the bed because you don't want it getting snagged on things. Also, in having it coiled up on the bed is going to allow for dependent drainage. So just like you would do with someone's Foley catheter, you kind of have it coiled up on the bed to let gravity help it drain. If you have it dangling off the side of the bed, then it has to work up against gravity to then go up to the drainage device. Question number 1. So just to make sure no one fell asleep during that awesome movie, we'll get some participation here. Your patient has recently had a placed chest tube. You note continuous bubbling in the water seal chamber and an oscillation where you are examining the drainage system. Which of the following is the correct nursing intervention for this type of finding? Is it A, reposition the patient because the tubing is kinked? B, advance the chest tube into the patient? C, increase the suction to the drainage system until the bubbling stops? Or D, check the drainage system for an air leak? I will give you guys a little bit of time to look that over and come up with some answers.
Teresa, it looks like most everybody is going with D.
D, yes, D is the correct answer. So in this example, A, reposition the patient because the tubing is kinked. That's not likely if you're having oscillation or you're seeing that float ball moving up and down. That tells you that the tube is being exposed to some interpleural pressure changes, so it does seem to be a functioning chest tube. B, advance the chest tube into the patient. No, we do not do that. And then C, increase suction to the drainage system until the bubbling stops. That will not stop the bubbling by increasing suction. And then, so D is check the drainage system for an air leak. So as I was just kind of explaining there, titling, so you hear people talk about titling. That means when the float ball is going up and down with inspiration and expiration in the water seal chamber. So it's that red ball there on the image off to the left there. When titling isn't observed, then you need to start looking for reasons for why that is. Could the chest tube be obstructed? Is it kinked? Is it clogged with debris? Has maybe the chest tube migrated out of the pleural space and then it's not being exposed to any of those intrapleural changes anymore? Maybe there's a problem with suction. Maybe check all of your seals to make sure that all the tubing is correctly sealed together. Or possibly there's been re-expansion of the lung. That usually takes around 36 to 72 hours. Obviously, we've all had patients with chest tubes that have been in place longer, but maybe the titling has stopped because the lung has come all the way back up. And then you won't see those big swings in intrapleural pressure causing that float ball to go up and down. So air leaks. We've mentioned air leaks already a couple times today, but just so to kind of drive home the fact, air leak is when you're looking in that water seal chamber down where the blue fluid is, you can see bubbling in that system. On the video, they did a good job of explaining, there's a graduating level of air leaks. So in the picture below, you can see it's bubbling all the way across to 5. That's a pretty large air leak. Where is the air coming from? So there's different places that air could be originating. It could be one coming from the lungs. So say someone had a lung biopsy and they got a natrogenic pneumo after it. They might have a tiny little hole in the lungs. So every time they breathe in air, air comes into the lungs and then comes out that tiny little hole and fills that intrapleural space. So that's where air could be getting pulled out of via the chest drainage tube system. 2, could be a problem at your actual insertion site, so on the patient's chest wall itself. Maybe you can even hear a sucking sound coming from their chest tube site. That means you need to do a better job of putting on an occlusive dressing so that there isn't a lot of outside air getting sucked into the intrapleural space. Or 3, it could be that there's some problem with your tubing or drainage. So where the patient's thoracic tube gets connected to the manufactured tubing for the drainage system. Maybe that needs to be reinforced with some foam tape. Maybe you got to check where your suction is getting hooked to the wall, where suction is getting hooked to your actual drainage system. You want to make sure all of those seals are tight. You can do a clamp test. So you would take a padded hemostat. You want to make sure it's a padded hemostat because you don't want to disrupt the integrity of these chest tubes. So padded hemostat, you can clamp it at the pretty close to where it inserts on the chest wall, so pretty proximal on the tubing, and apply the clamp momentarily. If the water seal chamber continues to bubble after you've clamped the chest tube, that means there's an air leak somewhere within the system, that it's not coming from the patient itself. So if you clamp it and the bubbling stops, then it was coming from the patient's intrapleural space or from the insertion of the chest tube site. Okay, question number 2. A patient just had a chest tube placed for a pleural effusion this morning. Which of the following is an appropriate finding when assessing the chest tube drainage system? A, rapid bubbling in the water seal chamber. B, 10 cc an hour drainage of serosanguinous fluid in the fluid collection chamber. C, the drainage system is kept at the level of the chest for optimal drainage. Or D, all of these options are appropriate findings. I'll give you guys a little bit of time to answer that.
Getting lots of B's on this one.
Yes, and the answer is B. Great job. So reasons for A not being correct, rapid bubbling in the water seal chamber. Well, like we just talked about, that is indicative of some type of air leak. Usually when someone has a pleural effusion, they shouldn't have an air leak. That's usually seen if someone had a pneumothorax. 10 cc's an hour, that's a pretty typical drainage for a pleural effusion. Sometimes it can be less or more depending on how often or when the chest tube was placed. C, the drainage system kept at the level of the chest for optimal drainage. No, we actually want it kept below the level of the chest so that gravity helps with the drainage. So good job, everyone. All right, now our drainage system looks like it is getting pretty full. So we're getting up to that 2-liter mark. So you want to, when we're talking about switching over to a new system, you want to be sure that you set up everything exactly as you had before. So if they had -20 of suction being applied before, when you get done setting up your patient's new drainage system, you want to make sure -20 is being set again. So to start, you're going to disconnect the patient from suction, use that slide clamp that comes in the drainage system set or kit. You're going to disconnect the manufacturer's tubing from the patient's thoracic tube, attach the new system immediately. You can unclamp and then reconnect your suction. In the video, they did show that you can collect pleural fluid samples. They had where they poked a needle into the tube. I don't prefer doing that because you could disrupt the integrity of the tubing and then have to replace the whole system if you didn't do it quite right. They do have a needle-free access port that you can kind of see that I've circled off to the side there. And that's really easy to use. So say a provider orders, they want a pleural fluid culture. This is where you could get a sample of the pleural fluid that they want sent down. So you'll swab that little needle-free access port with it's a Luer lock port with an alcohol wipe, usually for about 20 seconds. Then you can attach a 10 cc syringe to that port site and then withdraw the amount needed for testing. Put it in a biohazard bag with labeling for the patient's information, and then you can send it down to lab and they're able to do any of the pleural fluid analysis that was ordered. Okay, to clamp or not to clamp, that is the question. There are some instances where it's okay to clamp momentarily or with a provider order, but a lot of times you want to be careful when you're clamping someone's chest tube, especially in the case where someone had a pneumothorax and they had an air leak. Instances where it is okay to clamp the chest tube, you can momentarily clamp it when you are replacing the drainage system like we just talked about. You can do it when you're assessing for air leak locations, so that clamp test that we also referred to earlier in the presentation. If your chest tube becomes inadvertently disconnected and you are trying to get the drainage system device set back up again, say it got knocked over, the tubes popped apart, you can clamp the patient's chest tube in that instance, and then while you're waiting to get it reconnected. And then with physician orders, when we are assessing the patient's tolerance to chest tube removal, or when we are actually having the chest tube removal occurring, the chest tube will be clamped. All right. And reasons, I would like to point out reasons for clamping the chest tube before we do chest tube removal. So say the patient had a pneumothorax, they had an air leak for a few days, but then today they didn't have an air leak. There's no bubbling in that chamber. And it seems like their chest x-ray, the pneumothorax has resolved on imaging. So they will clamp that chest tube and reevaluate in about an hour. And that's to see if there wasn't maybe a very slow or intermittent air leak that then is causing some reaccumulation of air into that intrapleural space, which means maybe they need a little bit more time on the chest tube. Transporting a patient with a chest tube. I get a lot of phone calls about this. So imagine you have a patient that has, -20 of suction being applied to their chest tube, and then the provider orders a CT scan. So they have to go down to radiology, and they're not able to travel with suction on the floors. So in this instance, it's okay to remove suction. This is not clamping them. When you say remove suction, that does not mean clamp the chest tube. That means you set it to water seal or gravity drainage. If you clamp a patient's chest tube, And they had that for the purpose of a pneumothorax. Air could build up in that interpleural space and cause a tension pneumo, so you do not want to do that. Clamping a patient's chest tube when they had it for a pleural effusion could cause some backflow of fluid into the pleural space, so you also don't want to do it if they have a pleural effusion. And then when you're traveling, you want to make sure that you're keeping the drainage system below the level of the chest, so gravity is helping with dependent drainage. And then you want to make sure that drainage system remains upright at all times. And like the video showed, that there are some little hooks on the drainage system that you can put on the bedside for when you're on the go. Now, troubleshooting, some of the things that might happen if you have a patient with a chest tube. So say you walk in the room and you see that the patient has pulled out their chest tube. So maybe they got agitated and yanked it out themselves, or maybe they decided that they needed to do some jumping jacks in bed. I don't know, it's happened. But you want to immediately cover the insertion site with an occlusive dressing. This is going to help prevent outside air from entering into that chest interpleural space and causing tension. You want to, after you get that covered, you want to contact the provider. They probably need another chest tube placed, and that'll be, pending orders from the provider. What you do not want to do is try to shove the chest tube back in. So please do not ever do that. And then question number 3 here. The patient in room 322 uses call light to tell you that something is wrong with her chest tube. When you arrive to the room, you note the drainage system has fallen on its side and is leaking pleural fluid onto the floor. The chest tube has become disconnected from the drainage system. What should you do, or what should you prioritize as your next step? Is it A, clamp the tubing using a padded hemostat kept at bedside? B, place the wet floor hazard sign out and contact housekeeping? C, educate the patient about avoiding movements that may disrupt the drainage system in the future? Or D, page the on-call physician and await new orders? I'll give you guys a little bit of time with that.
Looks like everyone's going with A for this one.
That is correct. A is the right answer. So their thoracic tube has disconnected from the drainage device and it's been open to outside air. And so you don't want a bunch of air coming in from outside into that interpleural space. You want to clamp the tube immediately while you're trying to get either if you need a new drainage system to be set up, or if you're able to still use the drainage system that is there in the room. So padded hemostat and gauze should always, and sterile gauze should always be kept in rooms with patients that have chest tubes. B would not be the first step. You will eventually need to deal with the fluid on the floor, but that's not going to be your first order of business. C, educating the patient. Yes, you're also going to want to do that, but again, not your first step. And then calling the physician and awaiting new orders. This is something that is time sensitive. So, air could build up in someone's interpleural space rather quickly. So you may not want to wait around 5, 10, 20 minutes until your provider calls you back. So that is something you're going to tell them that happened, but first order of business would be to clamp the chest tube and prevent a tension pneumo from occurring. Okay, so say the chest tube becomes disconnected from the drainage system. So you're going to clamp with the padded hemostat like we talked about. There's a picture of a padded hemostat there in the corner. If you're able to still use the drainage system that's there in the room, you're going to remove the contaminated tip of the tubing and insert a sterile connector. And then you go ahead and reattach the drainage system as soon as you can, and make sure all those previous settings, so if suction was being applied, all of those previous settings get carried forward again. And then you're going to cleanse the tubing with ChloraPrep and allow to dry. So as your patients are starting to get better, imaging is looking better, they're feeling better, we're start talking about discontinuing the chest tube. So some of the criteria for discontinuing a chest tube, if it was placed for an effusion, you want the drainage to have really tapered off. If they're still draining more than 300 cc's of fluid a day, then that chest tube is not ready to be pulled yet. So typically, we want drainage less than 100 to 300 cc's a day. And on imaging, you want to make sure that the fluid has not accumulated. Again, on imaging, you want to see that that lung has actually expanded pretty well before you remove the chest tube. For pneumothorax, you don't want to have any visible air leaks and no bubbling in that water sealed chamber. You want to see that the lung has fully expanded, that there's no residual pneumothorax on chest x-ray imaging. And then like we talked about before, usually with a pneumothorax, they're going to do a trial clamping of the chest tube. And then usually you get a repeat chest x-ray in an hour just to make sure there hasn't been recurrence of your pneumothorax. In these times when you are clamping this patient's chest tube, you want to make sure that you're monitoring them pretty closely. You want to make sure that they're not having any signs of hemodynamic instability, becoming more hypoxic, cyanotic, having more pain, all those things. You would want to immediately unclamp the chest tube and call the provider, because perhaps that there's been development of a pneumothorax while that chest tube is clamped. So you want to monitor your patients really carefully after you've had them clamped. Okay, question number 4. Your patient had a chest tube removed earlier this morning that was placed 3 days prior for an iatrogenic pneumothorax following a lung biopsy. Over the last hour, your patient has become increasingly dyspneic. They have respiratory 35, hypoxic, they're now needing more oxygen, they're hypotensive, and they also appeared to be in respiratory distress. What is the most likely diagnosis, and what is your next step? Is it A, a tension pneumothorax, remove the chest dressing to release all the trapped air? B, sepsis, contact your unit manager to arrange transfer to the ICU for fluid resuscitation. C, tension pneumothorax, initiate a rapid response team and have a 14 gauge needle available for emergent decompression by physician. Or D, bronchospasm, page the RT for an as-needed neb treatment and place the patient on BiPAP.
Looks like they're going with C for this one.
That is correct. We've got some smart ones out there today. Well, good job, everyone. Yes, the answer is C. So A, tension pneumo, they got the first part of that right. But removing the chest dressing on the outside of the chest wall is not going to release any trapped air. In fact, it may actually introduce more air into the intrapleural space. B, sepsis. I suppose they could be septic, but given the timing that their chest tube was just recently removed, speaks more to, and the fact that they're having respiratory distress speaks more to something going on with the lungs that is in the acute setting. Tension pneumo, you can do needle decompression where they put in a 14 gauge needle, usually in the second or third intercostal space. And that way they can rapidly allow air to escape from the intrapleural space that may be building up. And then bronchospasm, again, probably not likely given the timing of this chest tube being removed, and placing a patient on a BiPAP that's got a tension pneumo, you're introducing a lot more pressure into that thoracic space, and that can also be dangerous. So good work on that one, everyone. So some concerning findings. I've already kind of touched on some things, but patients with a chest tube that have rapid and shallow breathing, increasing hypoxia, so say they were on 2 liters for nitrogen washout and suddenly you just had to crank them to 6. That's pretty concerning, and a phone call or a rapid response is indicated then. Cyanosis, if your patient is becoming blue, patient complaining of increasing chest pain, any profound bleeding that's happening, or any other signs or symptom of hemodynamic compromise. Those are all pretty concerning findings that you want to be sure that you're on the lookout with a patient that has a chest tube. Also, if their pleural fluid output is more than 100 cc's an hour, you'd want to call someone on that, or they have unexpected bloody pleural fluid draining. So say before they had some serosanguinous fluid draining out of their chest tube, and they got started on a heparin drip for a PE, and then all of a sudden you're seeing a bunch of bright red blood coming out of their chest tube and filling into the fluid collection chamber. That's concerning, and you need to call the provider for next steps. Another thing is if you see a lot of increasing subcutaneous emphysema. So say you've got this gentleman here on your left, and you drop off his food tray in the morning for breakfast. He looks good. You come back 2 hours later to get his tray, and he looks like he gained 50 pounds. Well, he didn't gain 50 pounds from eating breakfast. That's a lot of subcutaneous air that's developing. So that's air that's getting trapped under the skin. And it kind of feels like if you've pushed on a patient's skin that has subcutaneous air, it kind of feels like Rice Krispies under the skin. It's usually not super painful, but it is something that you would definitely want to call a provider if the patient is developing a lot of subcutaneous emphysema, especially if they just clamp their chest tube. So that air could be leaking out either from the chest tube side and tracking up the skin. Now it comes time your patient's getting better, their x-rays looking better, they're draining less fluid, or they no longer have an air leak for their pneumo. All of these things are leading up to chest tube removal. So this is usually done by either the pulmonary service or maybe interventional radiology. Sometimes they come up, if they're the ones that place the tube, they'll come up and pull the tube. At this point, the chest tube will have been clamped and no suction is being applied. You want to make sure that you have all of the supplies that you are going to need before you get started. So everything should be in the room, your foam tape, your sterile gauze, your occlusive dressing, a towel is very helpful. Then you're going to put on your gown, your gloves, your face shield. It's important to have your face shield on because there is some fluid involved and you don't want it splashing into your face. In the picture here, you can see that they've removed the dressing already. Sutures, if there were any present, you'll have that removed. And then there are two different schools of thought, pulling the chest tube at end expiration or at end inspiration. They've actually had some small trials between the two, and they haven't had any major difference between like post-pull pneumothorax development. But I was always taught you do it as the patient is breathing out. You want to quickly but gently pull the chest tube out, and you're going to have your occlusive dressing kind of on top. The reason you want to have that on top is because we don't want any air getting introduced to this interpleural space from the outside. So you want to make sure you have your occlusive dressing right there immediately on top of that chest tube site. Then you're going to apply your foam tape to the top of that and secure it. It is nice to have a clean towel at the ready. Sometimes there's some pleural fluid that comes out, a little bit of drainage, and it's nice to have something to set the towel or the chest tube on while you are busy securing the bandage dressing. And then you're going to dispose of the entire drainage collection system and tubing per your hospital protocol. And then, like we said, once your patient gets their chest tube removed, you want to watch them pretty carefully for any of those concerning symptoms that we talked about before, like hypoxia, bleeding, increasing chest pain, trouble with shortness of breath, or having any increasing respiratory distress. Those are going to be some big things to look for. Post chest tube site care. So you're going to leave that dressing in place for about 48 hours. You want to avoid this area from getting wet. You want to keep the dressing clean and dry. After about the 48-hour mark, you can remove the dressing and replace it with a simple Band-Aid. And then you're always going to want to review with your patients signs and symptoms of infection to look out for at that site. So if they're having increasing pain or swelling, redness or drainage, those are all things that the patient should be on a lookout for, because we'd want to get them on an antibiotic if there were any symptoms of infection. So kind of some big take-home do's and don'ts of chest tubes. So do always keep the drainage system below the level of the chest for dependent drainage. Always assess your dressings every 48 hours and as needed. You want to keep accurate documentation Date, time, and color per shift in the chart and on the apparatus itself. You don't have to keep color on the apparatus itself because that's people can look at it and see what color it is. And then you want to alert the provider if any of those concerning changes that we talked about comes up. The don'ts, you want to avoid clamping if there's ever bubbling in the water seal chamber, because you have the risk that that air can no longer escape and then a tension pneumothorax could develop. You want to avoid kinking of your tubing. You don't want the chest tube to dangle off the bed. You want to keep it coiled up on the bed to allow for dependent drainage. And you do not ever advance the chest tube into the thorax, into the chest wall. And when in doubt, please ask. You've got lots of resources at your disposal. We understand that not everyone is very comfortable with chest tubes, but you have a lot of resources that you can reach out to. Your charge nurse, your unit manager, your house supervisor. There's even, if you go to Methodist intranet search bar, you can put in chest tube. It brings up our entire protocol. It does have some good information there as well if you've got some questions. And then you can always ask your friendly pulmonary APP or pulmonologist if any questions come up. All right. Well, are there any questions? It looks like we've got a little bit of time left.
I'm just curious so I work on oncology and we see a lot of thoracotomies with our esophagectomies. And sometimes it's to suction and sometimes the order says water seal. So I'm curious, like what the criteria, I guess, is for having them on wall suction or water seal.
Yeah, and that's a provider preference. I feel like for the most part, we are pretty quick to put people on suction. So a lot of times when they come up and they've had like a pneumothorax, we put them on suction and are trying to get their lung to expand all the way. But there are some theories of thought that applying a lot of pressure and suction can actually do some damage to the lung tissue itself. So sometimes people are a little less aggressive and they watch a patient on water seal instead, so that there isn't a lot of pressure being introduced to the lung tissue and possibly causing some damage. You'll see some people crank it up all the way to 40. If someone's got, difficulty with getting the lung to kind of rise up to the top on X-ray imaging, sometimes you'll see people get a little bit more aggressive and go with those higher pressures. But we do, so say we had a pneumothorax patient not too long ago, and he came up and he was having a ton of pain from re-expansion of the lung. He had a huge pneumo, put a chest tube in, and was just having a lot of difficulty with pain. In that case, we didn't apply any suction, just to kind of help control pain. And so he did water seal for a day or two, and then we started some gentle suction to kind of help bring the lung up because it still hadn't expanded on its own after a couple days. So I think for the most part, that's kind of more a provider preference.
Actually, this is a couple of questions in one. Can you explain a little more about the manual valve on back? And at MJE, we do not have the padded hemostats. What would you recommend to use instead, or should we look into getting those?
So for the padded hemostat, if we don't have them at Jenny, I think if you just take some gauze doubled up on itself and then put that in between the little clamp parts, so then you're essentially making your own padded hemostat. We can look into ordering them, but it would be pretty easy just to make your own by just putting like a doubled up gauze on top of the chest tube before you clamp it. You just want to make sure you're not putting that direct metal onto the chest tube, because that could like maybe break the tubing or at least disrupt the integrity of the tubing. And then the manual valve on the back. Are you talking about the one that you press on when you're releasing pressure out of the water seal chamber? Yes. So in that video, there is that little valve that you can depress when there is a change in pressure order. So say someone was on like the -30 of pressure, and then they ordered a change to -20. In order for that change to kind of be represented on the chest tube, or I mean, eventually it will get down to -20, but to release that excess pressure that's being supplied, you press on that little valve and it will release the air down to -20. So it's just kind of a little bit of a faster way to get to the ordered -20 of suction. And then can you just use the clamp that comes with the chest tube? Yes, you can use that slide clamp. For the most part, it's depending on what size chest tube that they have in, like thoracic tube itself that the patient has going into their chest wall. Some of them are small enough for that slide clamp. It may not pinch it all the way down. So that's when you'd have to use like the hemostat. But I think some of them you could use that slide clamp for. From a value analysis, we've got another question. I'm going to read it off for you guys. Recently, there has been a supply chain discontinued or back orders with Heimlich or pneumostat valves. Any thoughts on other products you have used before? I have not used a whole lot of other products. The Heimlich valve is the one that I've used the most often. We actually have a patient that we just discharged from the hospital that had a Heimlich valve, and he's unfortunately had this chest tube in place for, I think it's been like 3 weeks. So we sent him, his pneumothorax has been stable. He has a chest tube in place. He has really bad emphysema. So his lung tissue is not very great for re-expanding and then kind of bringing itself back up. So he's had this chest tube in with a stable pneumothorax. And so that Heimlich valve, you attach on the end of his thoracic tube, and it's a one-way valve. So air can get out of that interpleural space, but that outside air cannot track back up through that tube. So sometimes you'll see patients leave the hospital with a Heimlich valve, and if they're waiting for hopefully the lung will heal itself and then be able to fully expand. As far as running out of Heimlich valves or other valve options, I'm really not sure. I'll have to look into that, but that's a good question.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.